So from an enterprise system level, how do you manage access, but then customize it to the local community? Do you get the local leadership community engaged? What does it look like from your lens?
Well, that's a really great question, particularly for our company where we're in 9 states. We've got over 50 hospitals. For those of you who know our brand, AdventHealth brand didn't really exist 7 years ago. And so before that, it was very much a federation of a lot of hospitals that all had Adventist Health at that point in common, but were their own independent, if you will, hospitals, so to speak. And so over the last 7 years, I would say our company has really evolved in the sense of what is it that makes sense to be decided at corporate, and how do you still ensure that the markets are owning and leaning into their work as well. And so we have coined that internally as our co-operating model, where our corporate team doesn't wake up thinking about how to run the markets in the regions. Our market team needs to wake up every day thinking about how to run that. What we really focus on, I think, at the corporate office is how do we leverage the size and scale of the organization to really gain the value that we can, for across the organization. And then I would say layered on more recently is how do we ensure a consumer or patient experience is somewhat consistent across the organization, so that, again, just 7 years ago, where we had a lot of independent facilities operating on their own, how do you begin to formulate what is the patient experience that should be felt, regardless if you visit us in Kansas City or in Georgia or in Florida? And so it's beginning to make those standards clear for us, make patient experience a huge part of what we do every day. We have a large group of folks very focused on that specifically, and really just begin to slowly iterate and bring our organization into a more consistent look and feel across it. So I think that it's working. It's working right for our culture. We're not a true, everything corporate office says needs to just come straight down, and that's the way that it is. We deliberate and have a lot of discussions with our markets to ensure that the right solution is really what is sought through time, consensus, and then we go after and we do what we say we're going to do.
Kind of create that framework, and then
that's right.
Yeah, nice.
What I'd say, I was probably remiss from my opening remarks, just introducing myself, just to really talk to you about kind of the areas that I am over from a Joint Commission resources point of view. So I lead the Environment of Care chapter, right? Environment of Care, life safety, emergency management, as well as our healthcare construction services. So, and that has been, although I was supply chain director for a while, learned a lot about sustainability. We can talk about that later on one of the questions. So, so really what I see kind of comes from that lens. When I was, as I was kind of approaching this question, one of the things that, kind of reminded me of is a story it was out of Massachusetts. In fact, it'd be 8 years ago next month. It was a story of a 34-year-old, Laura Levis, became known as Laura's Law in the Massachusetts area. And Laura, 34-year-old, was trying to access care, right? She was having an asthma attack. Head to the hospital, tried to make her way into the hospital, ultimately never made her way inside, passed away really steps from the entrance and out of view of the public. So with Laura's Law, at least in Massachusetts, for example, there's now a requirement for hospitals to conduct assessments, right? Risk assessments to understand not just wayfinding from the highway to the hospital, but when you get to the hospital, how can you make it clear on where that entrance is? I loved what I heard you mention about your one entrance now. My last organization had 92 entrances into the hospital. It was a large hospital. But But we have to think about this, and not just in terms of making it easy, but what about during the day? What about during the night? How do I get from the parking deck to the building? There's so many things that come into play. Another instance that I can think of, this happened to be in New York. That it could be anywhere. And I remember, so the first was really accessing care, right? The second is accessing the evacuation route, the exit. I remember standing it was at a corridor, an intersection. I want to say we were in the basement, and I was conducting an environmental care life safety survey engagement, and I happened to, as I was looking around, I couldn't see an exit sign anywhere in view, right? So I literally had no idea which way to go. So it's one of the things that, again, the life safety surveyor is looking for. Could I get out? Can I get out in the event of an emergency? So I started to, have a conversation with the client, about the need to make sure that our signage was visible. They had put a tremendous amount of wayfinding signage in place, but all that wayfinding signage was blocking the exit. So I was making the case, hey, look, we've got to be purposeful and mindful, as we approach this. I really think wayfinding is super important, especially coming from a hospital that had 92 entrances. We need to be able to get patients to and family members and staff and responding personnel to wherever it is that they need to be. As I was standing in that corridor, kind of making the argument, in this case, I'll be honest, the client was somewhat, kind of pushing back and arguing, a bit, which, number one, you don't argue with a surveyor, all right? So that's rule number one. Okay. Make no note. So, but as I was kind of making their point, and and I kind of pointed out, well, life safety code says this. This sweet older lady rounded the corner. It was perfect, as if I had paid her. And she's like, "Oh my goodness, I've been walking around the basement for I think an hour trying to find my way out of here. I can't find an exit sign anywhere." Oh my gosh, this client turned to me and he's like, "Okay, fine. We're gonna move some of the wayfinding signage." So I guess that's kind of what comes to mind.
Maybe you can talk to us a bit about what the Joint Commission might be looking for or asking about related to community when you're doing surveys now.
So again, remember, one of my areas is emergency management, and so when I think community for me, and again from the surveyor standpoint, I'm really thinking about, am I ready, right? Can this organization support the community needs from the standpoint of emergency management? So one of the responsibilities organizations have is they need to be able to kind of turn on a dime, right? We saw what happened right back in 20, and I certainly feel for your position, back in 20 as well. So and we've learned a lot from that, right? I mean, we've got some great things. We have DoorDash, so DoorDash is a great thing. I would say Zoom, and that technology has been pretty good. But we also learned a lot from a resources and assets point of view. I think many organizations thought they were ready to support the community needs, and then we quickly found out that we weren't, right? So I think from thinking about this question, it's really what can we do to kind of help healthcare, I guess, respond to this challenge, right? So healthcare organizations have to conduct what's called a hazard vulnerability assessment, right? And they do that, really it's every 2 years, but honestly, it's kind of an ongoing thing. As we experience disasters in a community, really the expectation is that an organization is going to take a deep dive into how they responded, where they performed well, and then where they did not, and then where they did not, to do something about it, right? That's really what Joint Commission is all about. I mean, if I were to boil Joint Commission down to two things, whether we're talking clinical, physical environment, emergency management, security. It's really taking note of how you're performing and understanding when there's need for improvement or room for improvement. We often talk about risk assessments from a Joint Commission standpoint. But then once we figure out, what we need to improve upon or where there's opportunity, the next and probably even more important step is actually doing something about it. So those are the two things that I look for as I make my way around kind of the country at different hospitals and organizations. So also from a community standpoint, it's important that we're able to communicate, right? Communicate with the community. And again, with that emergency management lens, if there's something that's going to go wrong, right, it's probably in the area of communication. So do we have the means to communicate? Do we have the means to get the message out? There's a disaster. Are we offering all of the services, right, that we would normally offer? Has something maybe was deemed non-essential, right? So did we make some changes, and can we communicate to the community, of what changes have been made? And then being able to even responding in a disaster situation where people are looking, let's say, for loved ones, and again, connecting the community to each other. And then I guess the last piece of that is, making sure that we have resiliency in the form of communications as well as, other technology, and we'll talk about technology later. But where that we can have conversation with the other response personnel, the emergency management agency, the fire, the police, as well as the Department of Health.
Technology can mean so much, from hacking to AI, et cetera, et cetera. So as your role as CEO, what keeps you up at night around that? What are the things that there's really a focus for you around that space?
I think there are multiple aspects to it. One aspect is just simply keeping up with technology. So keeping up with the implications of new technology available, both from a cost and an education and implementation perspective. I think something that I spend time on a regular basis talking about is, for instance, an example is surgical robots. We are, and especially as a physician, when we look at even our training programs and our fellowship programs, so much of the education and the training, especially for surgeons, is changing rapidly, such that they are now being trained pretty basically on getting used to robots, functioning with them in the operating room. So as we have a multi-generational workforce, the driver of one of the kind of recruitment and success metrics for recruitments is going to be the adoption of new technology. That's kind of one example. Of course, with things like the electronic medical record, right? We all love and hate the electronic medical record. And any implementation or any bolt-ons or any new additions or upgrades to it are associated with large-scale implementation. We have roughly 4,000 associates that work at our hospital. And so to implement something that touches every human being in the hospital is really complex. And how do you go through the process of doing it well, not just doing it with, from a checkbox perspective, doing it well so that you're benefiting by all other components of that technology. I think those are important things. Also, I would say from a physician perspective, virtual medicine has been great. In many areas, it's provided access, it's provided kind of timeliness to patients. But I would still say, and I may be old-fashioned in this, to say that there is a human and a relational component to a physician-patient relationship that I hope we never lose completely. It's unlikely to be so, I understand. But we should really be cognizant of the fact that that personal touch and that interaction really plays a significant role in the overall healing process. And so we shouldn't give it up all the way for this technology.